Well,
Shall we?
go ahead and get started.
Yes.
Okay.
All right. For all those of you who are listening to the recording, welcome. And want to present, this is Work Smarter, Not Harder, the Value of an Orthopedic Residency, and an introduction to the Movement for Life residency. So in this presentation, after we kind of introduce who we are, we're going to talk a little bit about what is an orthopedic residency, why you should consider completing an orthopedic residency after graduation, and the structure of a residency through the example of the Movement for Life orthopedic residency program. A little bit about us. My name is Dr. Vincent Kambe. I am a practicing physical therapist and the director of Movement for Life Clinic in Indio, California. I did my orthopedic residency with Evidence in Motion. I did my doctorate at Azusa Pacific and my undergrad work in kinesiology up at Cal Poly San Luis Obispo. Besides being the clinic director here in Indio, I'm also an associate instructor of research application at the College of the Desert's PTA program and the residency director for Movement for Life. Also, we have Dr. Callie Sleddy. She did her residency through Movement for Life. She did her doctorate in physical therapy at Upstate Medical University and her undergrad work at University of Idaho. She currently serves as the director of clinical operations for Movement for Life. So jumping right in, what is an orthopedic residency? An orthopedic residency is a post-professional learning opportunity with focusing on the orthopedic patient population. There's multiple residencies in different specialties that depending on what your interests are after you finish school and are licensed. Residencies, the key component and purpose of residencies is to offer that bridge from education into clinical practice by after you've gained the knowledge and been licensed, giving the opportunity to spend time with a mentor, as well as being re-exposed most of the time to the curriculum and the evidence once you've had a patient population to be able to base it, and it's not just theoretical now that you're out of school. It's designed to improve the quality of patient care and a clinician's knowledge in the area of orthopedics and for the orthopedic residency. The orthopedic residency also prepares you to pass the orthopedic certification exam, a designation that not all PTs have, and we can go into the evidence on the value of having your OCS as far as clinical outcomes and perceived stress levels of clinicians. There's currently 426 accredited residency programs with the APTA in different specialties, not just orthopedics, but neurology, I believe women's health, sports, and multiple other ones. So if you are considering a residency, the most common path to looking into the residencies and to applying for them is through the PT CAS system. This is where residencies and fellowship, which tend to be a little bit more specific with things like manual therapy, can be achieved. It's a central application service through the APTA. Both residencies and fellowship education programs are accredited by the American Board of Physical Therapy Residency and Fellowship Education, which is part of the American Physical Therapy Association. The PT-CAS system allows you to use a single online application and set of materials to apply for multiple programs, and allows you to look at a bunch of different residency programs. The fees currently are $165 for the first program that you apply for and $65 for each additional program. If you're interested in looking at the different residency programs offered through the APTA, there's some links you can go to below there with the PT CAST Application Help Center and a quick start guide to get you going. So we've talked a little bit about what a residency is, but the true question is why? Why would you want to spend more time studying and more time in school after you spent all these years in PT school. Uh, and I think for most of us, we're people who care about people and care about what we're doing and trying to improve the lives of others. And the value of a residency is really to improve the product that you produce. Yeah, I'd have to say that I know you guys are all at St. Augustine at the various campus, and it's a program that I think highly of. Currently in my Indio clinic, there is out of the 7 clinicians, we have 3 of them that are from St. Augustine's and graduates of St. Augustine's. We take multiple students, and I believe it's an exceptional program that really prepares you to be great clinicians and I think has a great amount of professionalism. Um, but it's still not real world. Like everything we learn in school doesn't necessarily transition to what's it like once you're treating and having to deal with the patients. You don't have that luxury of having a CI with their experience, uh, and so uh, a residency allows you to bridge that gap to make sure that you are the best possible clinician you can be. And I think first and foremost, that's what most of us should be focused on straight out of school is creating a product that has value, not only because we work in a profession where our actions affect others' lives. Uh, and so we want to make sure that what we're doing is performing at the highest level of research. And when you first come out of school, you don't necessarily have the clinical expertise. So the residency is great for helping to bridge the gap, excuse me. Uh, it also allows you to work smarter, not harder, on the clinical and non-clinical components of the profession. We work in a field that has a very high burnout rate, and one of those reasons is the lack of efficiency of many clinicians. And a residency allows you to work not only on how to be efficient and effective in treating your patient, but how do you manage the paperwork? How do you manage the non-clinical stuff that each and every one of us, regardless of where you see yourself in your practice, there will always be non-clinical and leadership skills required. And a residency is going to help you to refine those and be the most efficient clinician and avoid the chance of burnout. And then to be able to apply the components of an evidence-based practice. As I said, I think highly of St. Augustine and the students that I take from the program tend to have a good understanding of the current evidence. But when we're in school, it's purely theoretical. How do you apply that evidence once you have your own patient population? And the residency will allow you to, while you're treating patients, to look back at that evidence and review it with more clinical experience to be able to apply to the use of the residency in practice. And probably the thing that most residents tell me is the most beneficial is the ability to learn from the clinical experience of a board certified specialist. Uh, any evidence-based practice is consistent of 3 components. There's the research, the clinician's experience, and the patient's perception. Coming straight out of school, you may have your pie may be heavily reliant on the evidence because you don't have the clinical experience yet. And you're still learning how to interpret the patient perception component to it. And so being able to spend hours every week over the 1 year or so process with somebody who has years of experience and has sought to move past just being a practicing clinician, but being a board certified specialist, will allow you to glean some great insight from them and maybe learn from the things that they knew the mistakes they made early on in their career. So some evidence about residencies. Graduates of residency demonstrate advanced leadership skills and make higher income compared to non-residency trained clinicians. Residency trained physical therapists are perceived have perceived higher clinical competency compared to non-residency trained peers. Employers rate residency trained therapists higher than experienced matched colleagues in several important domains, including leadership, communication, clinical aptitude, evidence-based practice, and teaching. And for those of you who see that and may think that you're not going to be involved in any kind of teaching, unfortunately, you always will be. When they survey experienced clinicians, the thing that experienced clinicians find that they do that's most important is patient education. So in that sense, we are constantly teaching. So some things to look at if you're considering a residency. When considering a residency, some questions I want to look at is what's the structure and curriculum components of the residency? Every residency is going to be slightly different. The department it's going to be in. Are you more interested in outpatient physical therapy versus maybe a hospital-based orthopedic setting? Do you want to see more out of the clinic, on site, performing arts, field? Does the residency entail where you see your passions? Does the schedule match? Different residencies have different structures and clinical experiences and costs. There's some residencies that if you search through the cast, where you work part-time as a treating clinician, and then you work part-time as a resident. The resident pay is usually a diminished salary rate in some of these residencies. And so is it applicable to what you're looking for straight out of school? Is the hours of scheduling, does it require a lot of didactic work outside the clinic or on your own that you might not want to get into straight out of school after spending so much time in the books? And what's the cost? Obviously, to have a mentor investing in you, the time to develop the residency, those all have costs, and many times that gets extended to the resident in different ways, whether through a reduced salary, whether through a payback method or monthly payments. It's something to look at as you look at residencies. What are the qualification expertise of the residency staff? Credentials and experience requirements. Is your mentor somebody who has been educated on mentorship? Is it somebody? Are you their first mentee? Are they board certified? Which hopefully they are if they're instructing in an accredited residency program. And as I mentioned, does the program have mentor-specific training? The type of caseload, as we can indicate, is the caseload consistent with what you want to be practicing in? If you want to be in geriatrics, orthopedics, and this is more of a sports centered, is that really the population that you want to learn and grow through, or vice versa? Is there exposure to numerous types of patients if you're looking to be in general orthopedics? All questions you want to talk about and look at as you kind of study through the residency. What's the style of feedback, mentoring, and assessment? Every residency is going to have slightly different formats and mentorship. Is it more of an observation and then reflection afterwards? Is it group residents where you have one mentor overseeing 3 to 4 residents at the same time, which has its value but may not be what you're looking for? Is it consisted of on-site mentorship versus hybrid virtual mentorship, with your mentor being in a different practice or a different location and viewing you virtually? And how are you assessed? Is it quarterly assessments? Is it written? What's the structure look like? And those are all things you want to look at to make sure that they're going to fit into your learning style. What's available after residency to continue personal and professional growth? So if you've been in the mindset that residency is where you want to be and grow, well, what's that look like afterwards? Is this a program where you're there for a year and then you have to go find another job? Is this something where you're going to feed into the structure, have a great understanding of the structure of this company through the residency, and then move into being able to apply that within the company itself? All things to consider as you go through and looking at the residency process. Anything you'd add, Callie?
No, I think that was great, Vince.
So we wanted to kind of give you the example of an orthopedic residency through the residency that Callie and I lead here. So a little bit about Move for Life. We are a PT owned operated outpatient physical therapy practice. We have 26 clinics throughout California, Arizona, North Carolina, and in Virginia. We are also an ESOP, meaning that every employee in our company, whether it be the aide, the front office, all the clinicians, all the directors, they all have ownership and share of the company itself. We're privately held and always intend to be. And our focus has always been on mentorship and growth, from new grad mentorship to through our residency and development of great clinicians. So our residency is a 12-month APTA accredited orthopedic residency. It runs from July of one year to June of the following year. The overview of the components is it's 12 days of classroom lab instruction, comes out to about 120 hours that we'll delve into, 120 hours of independent study, didactic work, 150 hours of clinical supervision under your OCS mentor, 1,200 hours of clinical practice, which in a full-time treating clinician should not be hard to achieve, and 12 residency cohort meetings, essentially one meeting a month. So for our residency, and once again, every residency is going to be slightly different. In order to be part of the Movement for Life residency, you have to be a full-time Movement for Life employee, have at least 6 months of experience if a new grad with Movement for Life, or have at least 1 year of experience for non-new grad applicants. And why do we do this? Because we want you to be comfortable with the non-clinical stuff and just discovering who you are as an independent clinician. Our system, we have new grad mentorship during that phase, which is teaching you the documentation system, the billing system, all those components. I've mentored at least 15 residents over the years, and I've had some that started 2 years after practicing. I've had some that started 6 months, 1 year. I've only had one that started right out of school, and his very first day was his first day of residency, and he was really adamant about trying. And in hindsight, he said he'd never do that again because there was so much that he had to learn about just the daily stuff, and he would have gotten so much more out of the residency had he had a little time to just get his feet wet and feel comfortable being a clinician to start with. And the residents must be a member of the orthopedic section of the APTA. Why do we have that? So you have access to the independent study material that we use, the clinical practice guidelines. So the investment, so to give you an example of what a residency costs, residency cost is about $13,000 per year. For Movement for Life, this is Movement for Life specific, our residency is 100% subsidized by Movement for Life, meaning that the resident pays nothing for the residency. All we ask is that the accepted resident agrees to a 3-year commitment to the company from the start of the 1-year residency program on. And then obviously if the resident leaves prior to that, some prorated paybacks of that $13,000. So some specifics. So if we were to break the residency into 3 main sections, we have the lab sessions and cohort meetings, the mentorship and clinical practice, and the independent study and regular annual assessments. So lab sessions, do you want to talk about these ones?
Sure. Yeah. So our lab sessions at Movement for Life, what we decided to do was when we went through our accreditation process, we really wanted to offer a high quality level of didactic content to our residents. So we ended up partnering with USC, and Joe Godges, the instructor there, hosts our residents for, as we described, a 12 days of on-site time at the USC Health Science campus. And that time is broken up kind of in a combination of diving deep into those clinical practice guidelines, as well as manual therapy skills targeted, manual therapy and evaluation and assessment skills targeted around certain body regions. So for that first 6-day lab session, you start off with the lower extremity and move into the lumbar spine. For the first 3-day session, you go into the cervical and thoracic spine, and then the last 3-day session, you cover the upper extremities. They've added a lot of continued content as we've progressed, with our time through USC, including things like pain science, motivational interviewing, et cetera. So starting to work on things outside of just some of the more traditional didactic content. They utilize a really great platform. Some of you may be exposed to it already through St. Augustine, but they utilize a platform called PhysioU as their learning management system. And what the reason they use that is because it gives all of you as residents access to, fully professionally shot and narrated videos of all of the skills that you practice during the lab session, so that when you come back and are spending time with your mentor, you have it right at your fingertips to be able to go through, rewatch those skills that you practiced in lab, do them again with your mentor there on site. So it's been a really meaningful way for our residents to kind of apply that knowledge and have it at their fingertips again once they're not on site.
Great. So a little bit about the cohort meetings. We try to meet once a month with all the residents throughout the company. As we said, we have 26 clinics throughout the country, and so residents in all the different locations. And although they're being mentored by their individual OCS mentor, we try to get them all together once a month. And who attends is the residents, Callie and myself. And we design it as a once a month evening meeting. And a lot of times, so every resident has to present a case study throughout the year to the rest of the residents, as well as to the mentor, just to make sure that we want to have them be able to, once again, teach other clinicians, as well as to get to see their clinical reasoning and have the other residents see a clinician, one of their peers, and their clinical reasoning working through a patient. We also, on the sessions that are not, that case presentations aren't being, we're having group discussions. You're getting a chance to discuss with your peers in the residency about different patients, and it allows me, the residency director, to kind of see the trends and how people are thinking and where we are, and if there's any sidebar conversations we need to have. Inevitably, we always end up having some session that talks about post-op protocols and progressions. We always tend to go down some rabbit holes with exercise physiology and some of the more high-level patients, and just kind of exercise progression as a whole. But the residents tend to find a lot of value in it, and it's a great time to just kind of see where everybody is and where your peers are. Mentoring and clinical practice. So this is my jam. This is what I love to do. Every resident is paired with their OCS mentor. All of our mentors go through training of what we're trying to accomplish, help with understanding different learning styles, in formatting for the residency and the mentorship process. It works out to about 3 hours with your mentor every week. And although it might change based on the resident's need throughout the program, the general format is we'll usually sit in for about 2 hours a week with the resident as they're treating patients. Usually it might be more co-treating to start, and then more hands-off and reflection afterwards as the resident progresses through the program. 30 minutes of it is usually we'll sit down and talk about, hey, how are things going with patients? Any patients you want to chat about. This gives the mentor an opportunity to find out where the resident is and kind of assess clinical reasoning, but also help the resident get a handle on maybe some more challenging patients. And then another 30 minutes is usually through a manual therapy lab. The APTA requires a certain checklist of manual therapy techniques that must be mastered over the residency process. And the way we do it is I try to break it up body part by body part. So the first week we'll look at cervical spine and we'll say, all right, what's the most common differential diagnoses we see in the clinic? how is that patient going to present subjectively? And then the next session will be, all right, what are some clinical prediction rules for ruling this in? What's the most evidence-based objective testing to rule that in? The third one might be on appropriate exercises, highest level evidence for exercise. And then the next one, going through manual therapy, will review everything that the APTA wants you to master, but also I try to move through my 15 years of experience, I've found to be my most effective. And I don't expect everybody to be a cookie cutter example of me as a clinician, but it's nice if you can learn some big bang for your buck techniques to help certain differential diagnoses. Also, throughout the process, we've incorporated a lot of pain science in using the appropriate questions. I always teach residents there's two types of patients. There's those who will be persistent pain patients, or those who are persistent pain patients, and those who will be persistent pain patients if we don't use the right words, the right questioning, and help them form their thoughts and understanding of their pain in the right way. So throughout the process, we place high importance on the words that we use, the questionings that we use, and getting patients to be not just receivers of healthcare, but actively in control of their own healthcare. Also, if you're a full-time employee, you should have no problems, as we noted, meeting the 1,200 clinical hours of treatment time per year. And we have an automated system that, Callie, do you want to speak to that? Oh.
Yeah, sure. Yeah. So I can speak to Vince and I. One of our big goals in the residency is to decrease administrative burden and redundancies that the resident have to do that are not high value activities for the residents to be participating in. So we've worked really hard to automate things like conditions tracking, outcomes tracking, et cetera, for our residents, which are part of, the requirements of graduating and completing an accredited residency. But we work to track on a monthly basis and provide to the resident, a report of where are you at on your hours, where are you at on your percentage of required conditions by body regions, that you and your mentor can personalize your caseload as needed to make sure you're hitting those requirements appropriately, and help target your mentorship towards those areas of outcomes as needed. All right, and then I'll jump into independent study. So it tailors perfectly from what I just said, where Vince and I really wanted, when we looked at the independent study creation, our big goal was, again, to avoid redundancy and make sure that what we were asking a resident to do outside of their direct patient care time and direct time with their mentor was of value to both prepare them for that OCS examination, as well as to prepare them for, to be high quality clinicians when they left our residency. So the content that we chose to utilize is the orthopedic section monographs, as well as the clinical practice guidelines. And so with the monographs, what we did was we actually kind of pick and chose the monographs that we felt like were missing from the didactic content that you're going to receive in lab, and traditionally what maybe, may come up less often, if you will, in regular day-to-day clinical practice. So as an example, for Movement for Life, our content ranges from, up-to-date post-operative management for different orthopedic surgeries, clinical imaging, pharmacology, neurology related to orthopedics, screening related to orthopedics, and then tissue tolerances. So it was kind of some of the key areas where we felt like, as we worked with different cohorts of residents, that they were looking for a little bit more, a little bit more content or a little bit more didactic material related to those topics. And then clinical practice guidelines, we wholeheartedly believe that we should be treating to those. So they're a key part of our independent study. And so the time that it takes, we estimated that, there's about 2 hours of content per monograph in clinical practice guidelines that helps us get to our 120 hours. Our comprehension checks are just every orthopedic section monograph is built out with a study aid. We feel like that's great practice as a resident to prepare you for what the types of OCS questions are going to look like and be formatted like. AOPT has also put out specific quizzes for their clinical practice guidelines, again, to help practitioners be prepared to sit for those specialty examinations. And then we do our own item writing practice as residents, because if you can write like the test, the goal is that you'll be able to more appropriately think to those, that style of reasoning when you're going through an exam, because it is very different than our traditional PT licensing exam.
So the assessments. So for our program, we have three formal assessments performed by me, the residency director of each resident. And I always try to warn the resident, this isn't an assessment for you to fail or to kick you out of the program. This is just more another learning opportunity with another clinician and another mentor, and to just kind of help you and your mentor establish goals over the next 4 months. So we try to do an assessment every 4 months. Two of them are in person for us, while I'll go to the different sites, and one of them will be virtual. At least one of the assessments has to be where I am assessing the mentor as well. I'm trying to see the interaction, see if there's any kind of feedback I can give them on how to better prepare the resident. And then we provide formal feedback as I sit in on one evaluation and one follow-up in the assessment, and just get a chance to, as I said, really just do some goal setting for these next 4 months to help everybody reach the goals they're trying to achieve.
This is another thing, Vince talked about earlier, ways to kind of compare and contrast different residencies and what you can expect in terms of preparation. So this is just sharing, all accredited residencies are required to post their, recent program outcomes. So it gives you an idea. You can look at, the size of cohort. So, how big is my cohort? Do I feel like I'm going to get adequate attention? What is that ratio of cohort to resident? How many, what graduation rate are we seeing? What is the attrition? Who falls off? What's that graduation rate? And then of those residents that do test, what is that pass rate? So you can see our results there, and happy to answer any questions on those. You'll see the asterisks for years where, we had people that for life situations chose not to test, but other than that, we've been able to maintain a really high pass rate.
That's kind of the overview of a residency using the model that we have, and kind of the importance of why I encourage each and every clinician to consider a residency to help you become a less stressed out, more proficient clinician, and allow you to better help your patients. Any questions?
Stacy sent me a message that she was having some connection issues. It looks like it might be better, but we'll see. I'll watch the chat just in case.
No questions.
Okay.
No questions right now. Thank you.
Perfect.
Of course. Please feel free to reach out. I've included our emails at the bottom here. If you have any questions about residency as a whole, anything we discussed today, or the Movement 5 residency or opportunities for clinical rotations in Movement for Life, please feel free to reach out to us. Other than that,
I'm definitely interested.
Excellent.
No, and we're happy, as Vince just mentioned, we also have, a PT student rotation program. We're happy to discuss those opportunities with you as well. Also happy to discuss kind of what new hire onboarding looks like, just to help as you guys make those big life decisions of where am I going to go for those first couple, integral years after I leave school, and what are those opportunities that can be presented. Arming yourself with those questions and what to ask and what to compare is what I would encourage all of you to lean into and do.
Awesome.
Thank you, Vince.
Of course. Well, if no further questions, then thank you for your time, and have a great afternoon or evening.